Okay. All right, we'll go ahead and get started. Hello, everybody, and thank you so much for joining us today. I'm Jean David. I'm a community neonatologist just at Northwest Community Hospital and Endeavor Health in Arlington Heights, Illinois. I'll be the moderator for today's talk entitled Experiences Building a Palliative Care Program in a Low Resource Setting with our speaker, Dr. Glen Komatsu. Our next webinar is called Do-Overs, Repairing the Clinician-Parent Relationship, and that will be with speaker Dr. Terry Major-Kincaid, and that will be on December 9th, 3 p.m. You can see the QR codes for the registration on the slide. So for today's talk, our three objectives are first to discuss complexities and limitations within pediatric palliative care and challenges in building a pediatric palliative program. Number two, to introduce concepts for palliative care in a chronic setting, including post-discharge considerations and differences between models of care. And number three, discuss ethical considerations with complex cases, such as quality of life perspectives, end-of-life care, and supporting families and staff. And as I mentioned today, I have the pleasure of introducing and interviewing Dr. Glen Komatsu. Dr. Komatsu, or as he prefers to be called, Glenn, grew up in Phoenix and attended undergraduate school at the University of Arizona and medical school at the Arizona College of Medicine. After completing a pediatric residency at UC Irvine affiliated hospitals and a neonatology fellowship at Long Beach Memorial Miller Children's Hospital, he entered private practice and went on to join the NICU at Providence Little Company of Mary Medical Center Torrance, where he served as medical director and director of bioethics. In 2004, his passion for palliative care led him to complete an adult palliative care fellowship at Dana-Farber Cancer Institute, Brigham and Women's Hospital, Massachusetts General Hospital, and Harvard Medical School. And then in 2005, he returned to Providence Little Company of Mary in California to develop a pediatric hospice program called Trinity Kids Care, which is now one of the nation's largest hospice programs in pediatrics. He now serves as Chief Medical Officer for Providence Trinity Care Hospice and Regional Palliative Care Southern California, and Medical Director for Trinity Kids, Pediatric Hospice. Glenn, thank you so much for joining us today. Before we begin, I wanted to let our audience know that they can put in any questions during our discussion into the chat, and we will incorporate those into our conversation as time permits. And I'd like to start our interview by asking you to tell us about yourself in your words, especially as it is so unique and inspiring to hear about your journey to palliative care.
Yeah, thanks, June. I wanted to thank June, first of all, and her peeps, Aaron and Christine, for putting this talk together and inviting me. So palliative care in children is not shall we say, a really well-supported topic. And so I really appreciate shining some light on this area. So my origin story, as June said, I'm from Arizona, and I just want to say a few sentences about my background. I'm a third generation Japanese American. My grandparents immigrated from Japan on the turn of the century, early 1900s, and then my parents were born here, and they all together went through the Second World War. And so they experienced, a great deal of racism and discrimination. The irony of my family is that my mother was in a concentration camp, and my father was drafted into the U.S. Army. So the reason I mention that is because that really informs sort of my worldview and how I look at medicine. So my parents taught me a strong sense of sort of integrity and humility, the value of hard work. And so, that really leads me to advocate for children, especially children that or dying or chronically or terminally ill that aren't curable, that frequently the rest of medicine really doesn't spend a lot of time with because we're not comfortable with that, and because our job, of course, is to save lives and help babies live. So when I was in the NICU, I loved that. First of all, I loved taking care of babies, and but over time, the ethos of neonatology was a little difficult for me. And I have huge respect for all of you that are still doing this work. But for me, the ethos of saving every baby at all costs, no matter, you know, kind of what the parents thought, there was always one more thing to do. That didn't sit well with me. People were not as concerned about the pain and suffering that we were putting the babies through. And so I thought, there must be a different way. And that's what palliative care offered when I started reading about it as it emerged in the late 1990s, early 2000s. I thought, wow, this is a way to really address pain and suffering in a way that I wasn't previously exposed to. The palliative care did not exist when I was in med school, when I was in training. And so this emerging field coming out of the hospice world was very intriguing to me and gave me some tools to address pain and suffering. So I luckily I have a very understanding wife and family. So at age 50, after 20 years in the NICU, I moved the family back to Boston and did an adult palliative care fellowship. I thought about doing peds. At the time, there was only two pediatric palliative care fellowships in the country. One was at Boston Children with Joanne Wolf, and the other one was at Akron with Sarah Freeberg. But there was no pediatric palliative care going on in Los Angeles at the time. So I did the adult program, which was more well developed. And now I take care of both adults and children. So I came back in 2005, started the adult palliative care consult service at Lower Company of Mary Torrance in an adult community hospital, and then took over the medical directorship of a nascent pediatric hospice program called Trinity Kids Care. When I came back, they had just started the program in 2001. They had 5 or 6 children on service. And so over time, we've been able to grow that service to today, our census is around 60 to 65 children on a given day. Still very small for a metropolitan area the size of Los Angeles and Orange County, but we are the only pediatric hospice that's dedicated to children in LA and Orange counties with a pediatric staff, nurses, social workers, chaplains, home health aides that are all trained in taking care of kids. So that's sort of my origin story. Um, the work has been extremely rewarding, and honestly, I miss the people, but I never looked back from moving on from the NICU.
That's such a wonderful story, Glenn, and it's really inspiring to see somebody who was so motivated and passionate about this to go and start such a new venture. And, as we've talked about in our many previous discussions, pediatric palliative care is such a limited resource to the point where you uprooted your entire family to pursue this additional training. So
Yeah.
in your words, did you go about starting such a now successful palliative care and hospice program, especially surrounded by these limitations?
Yeah, thanks, June. That's a great question. People ask me that kind of routinely, and my answer is that you have to have the administrative support of the institution. If they are not behind you, I don't care how good you are as a clinician, your program will not thrive. So you need that. I had the backing of the Sisters of Little Company Mary, the administration, the board of directors. Um, so that was key. And then the second thing is you need a physician champion. I thought about doing this without fellowship training and realized quickly that in order to have any credibility, and I really needed to have subspecialty training. So that I had something to offer that was currently not available.
Yeah, and to have those made those connections and done all of that, that's certainly a lot to face. We've also talked a lot about the breadth of what Trinity Kids has to offer and some of these post-discharge considerations or chronic care considerations for very complex palliative patients or any infant really with ongoing medical needs. And I will be the first to say, I found some of these differences very confusing. So I would love for you to explain to our audience what are the differences between inpatient or home-based hospice or the concurrent care model? How do you decide between these?
Yeah, it's a very confusing model, quite honestly. So first of all, hospice, many of you probably don't realize it's only started in the about 1983. Congress approved the hospice benefit for Medicare recipients. So that was great. But of course, children don't have Medicare. And so, unfortunately, all the Medicare guidelines got transferred to pediatrics. So the main guidelines were you had to have two physicians say that the patient, or in our case, the baby, has 6 months or less to live, and there has to be two doctors, and the parents have to agree. So, that prognostication in general is not something that we physicians are that trained in, and we're not that good at it, and especially with kids. And when you think about the really difficult diagnoses that you all face in the NICU, like the severe trisomy 18, 13, HIE, the severe congenital anomalies, who knows how long those kids will live. And so that 6 month prognosis does not work very well, but we're stuck with that. So what we do in our program is we just document decline over time and justify keeping children on. So when we bring babies on, we certify them for 3 months and then another 3 months. And then after that, every 2 months, we have to see them and attest to they have a 6 month prognosis. So we've had, for instance, trisomy 18 babies that have lived for years on our service because the parents want to keep doing aggressive palliative care to keep them alive. So what also helped, fuel the census, our census, was this idea of concurrent care. So concurrent care was a little known clause in the Accountable Care Act in Obamacare. And what that clause says is that children who meet hospice criteria, meaning they have a prognosis of 6 months or less, can also receive concurrently aggressive palliative care. So that was a huge boost to our numbers because parents then saw that they could get hospice services at home and they could get aggressive palliative treatments like blood transfusion, like chemotherapy, like radiation, repeated hospitalization for aspiration pneumonia, things like that. So that's how children can stay on for years because they go back and forth in and out of the hospital. So I still have to say they have 6 months or less to live if the disease took its natural course.
Mm.
And then let me say a little bit about the hospice benefit. What does that entail? So, like again, these are Medicare guidelines, which stipulate that a nurse has to visit every week. So physically in person, not virtual, and check on the child, check on the parents, the family, see how they're doing, make sure the child is comfortable and their symptoms are managed. So also under the hospice benefit, we supply equipment like oxygen, um, BiPAP, TPN, um, so suction machines, diapers, and formula if they have a tube. So we supply that, and we supply all the medications that are related to the hospice diagnosis and related to symptom management. What we've done, though, is because so many of these palliative treatments are expensive, we've had to negotiate with payer sources about who's going to pay for what. Because if we paid for respirators, for instance, that would not be financially feasible because our reimbursement is on a per diem basis, and we get roughly $250 a day to take care of a child or an adult. And so, we actually, on the children, we lose money on every child every day because our costs outweigh our reimbursement. So Medicaid is our best payer. So that's what the hospice benefit requires and entails, which is why there's so few pediatric hospices across the country. The business model is terrible. Nobody with any kind of business sense would start a pediatric hospice. So the way we're able to sustain this, and we've been able to sustain it now for 25 years, is the dedication and the commitment of our foundation to raise the money to supplement this program, supplement the shortfall. And so every year, the foundation raises roughly $1 million to help our pediatric hospice and our pediatric palliative care programs just break even.
It's really unfortunate that this can't be a nationwide resource for all of these
Yeah.
patients that we send home. And I guess what advice do you have for those of us who don't have this kind of program, available at our hospital? Are there any resources that should or can be provided for patients that are discharged under hospice care?
Yeah, it's not easy. But first of all, I just want to say that every neonatologists, all of you that are on this call are doing palliative care, right? You take care of chronically ill, terminally ill babies every day. And so, but the question is, are there a few cases that come along that people are just like kind of not knowing what direction to go? Um, Kids that are technologically dependent and kind of stuck in the NICU. Those happen because you guys are so good at keeping babies alive. But then you get to a situation where now what? So, it's really hard. And so as you know, most of these children then pretty much live in the hospital. This happens on the older children's side too, with in the PICUs, right? There are cardiac kids, oncology kids, metabolic kids that just are so dependent on all of your technology that there's no other place for them to go. Um, we, in our hospice, we're taking care of higher and higher acuity patients, and we have parents that set up little mini ICUs in their home, and they're literally, giving IV meds at home, TPN, continuous infusions of milrinone, PCA, opioid PCAs. I mean, triple lumen. I have one child that carried around a backpack because she had 7 IV infusions going at once. So she, with all of her IV fluids and infusions, she had to carry around a backpack. So, it's just hard. And I think all of you do the best you can. I think the one thing I would ask you to think about is, think down the road about these children, about their future. We're so fixated on today, getting this baby through today, this week. We don't think about the consequences of our actions. And the other thing is think about, say you are planning to send the child home at some point, think about it from the parent's perspective. In the NICU, it's so easy to order whatever you need, IV meds, IV fluids, IV whatever. But, that's not possible in the home setting, generally speaking. So how can you transition to oral meds, NG or G-tube meds? We use a lot of rectal meds, which I know is not the general practice in hospitals, either children's or adult hospitals. But rectal meds are very effective. The venous plexus down there is very rich, and the absorption of meds is pretty good. So we get pain meds, give seizure meds, give all kinds of meds rectally. And there are rectal catheters called Macy catheters that are specially designed for that.
Mm.
So you have to be a little more creative when you're talking about transitioning babies from the NICU to the home setting. You just don't have all the technology, and you have to develop a comfort level with not having labs, on a regular basis, not having x-rays, scans available on a regular basis.
I think it's so important that you highlight how, and it's so important for us to hear your perspective on this because as inpatient providers, we're so used to seeing just that side and growing used to doing more and more and more as medicine gets pushed even, kind of further advancements. And so to hear more about the outpatient or chronic care home considerations for these patients and how that picture looks is such an important piece that it's so wonderful to hear your perspective on that. And overall, what I'd love to hear is your approach in addressing some of these ethical considerations, because I think, there's a lot more now that we are aware of in terms of palliative care considerations in the NICU. But you've had, as we've talked a little bit about some of your cases that have been particularly challenging, cases like stopping nutrition in the NICU. Like, how do you go about making these recommendations or supporting things that can be quite challenging and not necessarily in line with staff perspectives or parent perspectives and whatnot?
Yeah, thanks, June. One last thing about the previous question I just saw is that you could partner with a local hospice, adult hospice, if they
Mm,
have any staff at all that have a comfort level with children. And if you, the neonatologists, are willing to be available to their medical director for consultation and to answer their questions and to help manage the kids, then that's a possibility. And that's a model that's done around the country, is that because there's not enough pediatric hospices, adult hospices try to step up and take, a handful of babies on service. Babies in particular are frightening to adult hospice providers. I mean, there's a reason they went into adult medicine, right? And babies are the furthest thing from their comfort zone. But if you stay involved, the NICU staff, not just the doctors, but NPs, nurses, social workers, chaplains, to sort of guide the hospice staff through these cases, then I think it can be done. So I've seen that happen also.
mhm. That's great. That's a wonderful tip and something definitely I'll keep in mind.
So, so moving on to your ethics question, as all of you know, ethics is ethical dilemmas is really, again, just part of neonatology. And I got interested in ethics back when I was a fellow, and the Baby Doe case came down in Indiana.
Mm,
And for those of you that are not familiar with that case, that was a baby, Jane Doe, that was born with trisomy 21 and a tracheoesophageal fistula, the usual variety. And the father was a special ed teacher, and his wife, with the obstetrician, um, so support, said, this is not, they heard about all the issues with kids with TES, how they would, the issues that they would go through, the surgery and the long-term issues with esophageal stenosis and things. And they said, if you put it all together, that's not the quality of life we would want for our daughter. And the pediatrician and the hospital disagreed with them and took them to court. And so, long story short, it made its way through the lower level courts all the way to the Indiana Supreme Court, where actually they never ruled on it because the baby died. So, but Washington heard about it. This was during the Reagan administration, and their Secretary of Health, Education, and Welfare at the time thought this wasn't correct, this wasn't appropriate, that these children need to be more protected. And so the baby doe regulations came down. And again, long story short, the Academy of Pediatrics challenged it. Um, there were many challenges, AMA, And so those regulations were ultimately thrown out as well. But what happened was Congress revised the child abuse laws and made it medical neglect a form of child abuse. And so if you neglected a child medically, then that was fell under the umbrella of child abuse. And so that had a pretty chilling effect on all of us, doing pediatrics, taking care of very sick babies and children. And so the legacy of that continues to this day. And so with regards to withholding fluids and nutrition, artificially administered fluids and nutrition, um, some people feel that that is part of basic care, and therefore I'm never going to stop that. But the Supreme Court also ruled in an adult case, Nancy Cruzan, who was a woman in her early, I think late 20s, early 30s, was in a car accident and left in a permanent vegetative state. Her parents wanted to withdraw gastrostomy feeding, and the state of Missouri challenged that, saying, we don't have any written evidence that that was what she would have wanted. So, a long story short, went to the Supreme Court of the United States, and the Supreme Court said artificial nutrition and hydration is medical treatment. And since it is medical treatment, it can be accepted or declined. So that extrapolated to people, to children, and to people who should not speak for themselves, that also applied, that right also existed for them. But the state of Missouri, though, also, they actually won that case because they, the Supreme Court said that the state could determine the standard of evidence that a person would not want artificial fluids and hydration. So it wasn't enough for the family to say, we know our daughter, she would not have wanted this. She did not have it in writing. So, that is kind of the background information about artificial fluids and nutrition, and also the baby dose case informs pediatric bioethics. And so as a result, people feel like artificial fluids and hydration in children are not medical treatment. It's like more like food, and we never take away food from anybody, right? Especially a
Right.
baby. So, that is socially it's been very hard to socialize, artificial fluids and hydration being optional for babies.
Mm-hmm.
And so depending on the philosophy of your NICU, the culture of your NICU, and, sort of your local Department of Children's Services, how they feel about that. If anybody reports this case, of feedings being stopped in a baby, if you have kind of a enthusiastic social worker who doesn't agree with that, reports it to DCS as a mandated reporter, DCS could take that case on, which, by the way, they don't know what to do with these cases. Judges do not know what to do with these cases, but it creates a lot of angst, as you can imagine.
Mm-hmm.
And those of you who have done this, I did it several times when I was in the NICU, and it was hard every time. And there were nurses and staff that did not agree with it every time. But the consensus was that parents had the last word. And so overall, we supported the parents' decision. But it's still hard, even in 2025, even though the Baby Doe case happened, you know, 30 years ago. And
Mhm.
Cruzan happened in the 1990s as well.
I think another one of the challenges that we have is when we're not just kind of allowing that to happen, but also determining at what point do we draw the line of escalating care? Because we,
Yeah,
in cases such as HIE, where there's, cases of end organ failure in these cases or neurologic devastation, and you just keep going and going, at what point do we draw that line? And so it's
yeah,
finding the right, well, there's no right answer.
yeah,
Finding how
yeah.
to navigate that is such a challenging thing to do.
It is hard. I mean, do you look at an HIE baby as neurologically devastated, or do you look at them as handicapped?
Yeah.
And so it's, if you look at them as handicapped children have rights, and we should take care of them like we take care of any other child. If you look at them as neurologically devastated with no quality of life, then you would think about withholding or withdrawing care, so treatment, not care, but medical treatment. Like maybe you wouldn't treat the next aspiration pneumonia aggressively with a respirator. You give antibiotics, but maybe not a vent, for instance. So, but it's very hard. Depends on the culture of your NICU, the philosophy of your neonatologist about how they see this kind of situation. And there, as you said, there's no right or wrong answer, just difficult decision.
I'd like to hear a little more uh, about your experience seeing these families with children long term, because there are so many kids that I can think about where we, in our minds, deem them to have this quote unquote poor quality of life. And you see these kids as their long-term chronic care provider, um, just, kind of going on towards. And what exactly is your take on these perspectives? What is your take on the parental perspectives, the family dynamic, how their families are impacted, all of these things?
Yeah, it's very humbling to see these children nested in these families at home and how dedicated these families are to taking care of these children. Even children that are vegetative, that never open their eyes, they never smile, they don't respond, they're vent dependent, G-tube dependent. But these children give those families meaning. Parents, it gives them, um, it justifies why they want to be parents in the first place. And it's pretty inspiring. And I really had a lot of my biases exploded by these families. On the other hand, after they've taken care of these children for years, sometimes these parents then say, you know, after the 25th hospitalization in the last 2 years, like, my child is now suffering. And I always am very careful not to say that. I ask the parents, do you think your child is suffering? You know, what do you think your child's quality of life is? And they say, no, he's not suffering. He's not in pain. And I say things like, it's not just pain. It's about the pain of not being able to go outside and play with their sibling, the pain of not being able to go to school, the pain of not being able to experience eating and food, um, the pain of not being able to know their God. So I ask parents to consider pain at all these different levels. And over time, thoughtful parents really think about this and they say, I see your point. Like, what are we doing here? And so they sometimes make that courageous transition to comfort measures after 6 months, a year, 5 years. You know, they see that. So our job is to, as a hospice team, palliative care team, is to keep showing up, to keep providing support, to keep listening, and to, support these parents through this journey. We don't have the answers. I don't have any magic wand. I don't have any way to take away the pain of losing a child. Nothing I can say or do would ever help that. But we can keep showing up. And parents really appreciate that because many times they feel abandoned by their healthcare providers, like in the children's hospitals, because they have incurable disease. Or they feel judged, like, why do you keep bringing your child back with aspiration pneumonia? They're on hospice. Why do you keep bringing them back? And so that judgment is really weighs on parents. And so I would encourage all of you in the audience to really be aware of your biases. Really, we all have them. The idea is not to have biases. The idea is to be aware of your biases and not pass those on to the families that you're caring for.
I think it's always a challenge in approaching these family conversations that we have and defining what suffering means, because it means something different for every single patient, every single family. And some of those phrases that you use, those questions that you used are so helpful in terms of guiding us even to like giving us good information in terms of how we can ask these questions in a really thoughtful manner. So thank you for that.
No,
Um,
absolutely.
you've touched on this a little bit already, but how do you manage pain in some of these complex situations? And what kind of challenges have you had in going about managing pain, whether it's helping families or providers even who don't think that their child is in pain, any situations like that that may have arisen?
Thank you. That is a whole nother hour
In the
discussion.
5 minutes we have
But
left.
pain is, as all of you know, just really a difficult problem in medicine in general. I think when we're in the middle of an opioid epidemic and opioid shortages, treating children, especially babies, aggressively for pain is challenging. Um, I really believe in aggressive pain management, but my pediatric colleagues in the children's hospitals, and I work in the middle of four of the best children's hospitals in the country in LA and Orange County. Um, I will tell you that they all, in my opinion, my humble opinion, they undertreat pain because they're worried about overdose, they're worried about apnea, respiratory depression, addiction, all of the I would call them myths around opioid use and pain management in general. So some conditions are just really painful. And, in newborns, it's hard because when they cry for any number of reasons. But if you know they have a condition that causes pain, like if you have a newborn with cancer, with metastatic spread, if you have osteogenesis imperfecta, there are conditions that are painful. I would encourage you to treat them. Um, I think if you do it in a judicious way, growing up very carefully, it can be done very safely. But it's hard. Again, our biases are really show themselves with respect to pain management.
Mhm. Thank you so much for that. Some of your thoughts on pain management. I know that opens a whole bucket of other questions, but appreciate having even some of your hearing some of your thoughts on that. Before we kind of open questions to the group, I just wanted to ask, do you have any final lessons, any final advice to impart on our group today?
Yeah, thanks, June. I would just, you know, the technology in the NICU is incredible. Now, you can save smaller and smaller babies. You do, really amazing treatments that can help save babies. But I would just ask you to remember, why you wanted to be a doctor in the first place. Most of us would say we wanted to help people, right? And so just remember that. And remember that what parents really appreciate, they know or expect your technical expertise. What they remember and what impacts them is your kindness and your compassion in dealing with their baby as a unique human being and dealing with them as a unique family. So if you can keep that always top of mind, that goes, that's really makes a big impression on the families that you care for.
There's this saying that we use in our hospital called remembering your why, but it is a lot of just remembering why you entered this in the first place, remembering that compassion that you have, all of those things, and it's so important for us to come every day with that perspective in mind. I just wanted to now transition to our Q&A because I'm seeing a question pop up here. Um, what are some signs and symptoms that help families identify as treatable discomfort when it is unclear if the condition is painful?
Yeah, I mean, as you all know, as well as I do, there's many things that these babies have, many conditions. So, are they crying because they're refluxing? Um, so if they have a condition that predisposes them to reflux, that's a very treatable condition. I use Raglan a lot. I think it works well. Um, are they crying because they're neurologically really have severe neurologic damage? So we call it neuroirritability. Many of the trisomies have that, HIE babies. Is there a seizure? Then you give anti-seizure meds. If it's irritability, but not seizures on the EEG, then, giving them something to calm their nervous system. So I like phenobarb a lot, even though most pediatric neurologists never use phenobarb anymore. It's really good for neuroirritability. It's long-acting. It's well tolerated. The safety of phenobarb is well established in terms of respiratory depression. and it really helps babies stay more calm. The last thing you want is a baby that is just fussing and crying uncontrollably for hours on end. So, and then, pain is sort of the last thing I consider, depending on the condition, and then using small doses, of morphine, dilaudid, fentanyl, whatever you have a comfort level with, and just seeing, you know, and really collaborating with the nurses, because they're the ones at the bedside for 12 hours. They know these kids. Talking to parents, they spend hours at the bedside. They know these kids, these babies. So I would ask the nurses what they think. I would ask the parents what they think, and then go from there. I think the other takeaway is really try to look at your care and treatment of these babies and families as a partnership, that their input is valuable and your input is obviously valuable. So if you treat parents more like partners in this journey of their newborn, again, that shows a level of respect and kindness that parents really appreciate.
There's one more comment in our chat that I'm going to echo, which is thank you so much, Glenn, for sharing your experience and your wisdom. Um, you can, for everybody on the group, thank you all again for joining. If there's any last minute questions or if there are any questions that you think of even after our webinar today, Glenn has graciously said that he would help with any further conversations or discussions that you would like to have. So please go ahead and forward any of those to Aaron.